Hello everyone, I'm Aaysha Cader, this is PCR Online, and we are coming to you live from ESC Congress 2024 in London. I'm delighted to have with me Dr. David Ferreira from the John Hunter Hospital in Australia. David has presented the SCOFF trial as an ESC Congress hotline that is on the safety and care of no fasting prior to cath lab procedures. Welcome, David.
Thank you very much. Thanks for having me.
Yes, so tell us a little bit about the rationale and the design of the SCOFF trial. We've had a couple of trials regarding fasting versus non-fasting. Tell us about your design and why it's different.
Yeah, so I think this question is of great clinical importance. It's important to us as healthcare providers, but more so it's important to the patients that we treat. And millions of patients around the world every year undergo these procedures, both coronary and device-related procedures. So their pre-procedural management is extremely important. Currently, the American Society of Anesthesiology recommends fasting prior to procedures that require conscious sedation. And this entails 6 hours of solid food fasting and 2 hours of clear liquid fasting. Many of our audience would be aware of the Chow Now trial, and it made waves, published an abstract form confirming non-inferiority in a single center randomized control trial when you remove fasting requirements for these procedures that require conscious sedation. And so we wanted to design and perform a real-world, multi-center, pragmatic trial investigating this topic. And so we had a prospective, randomized, open-label, blinded endpoint design. Of course, you cannot blind patients to whether they eat or drink.
Yeah.
But we had a blinded clinical events committee who adjudicated all primary and secondary outcomes.
Yeah.
We had a non-inferiority Bayesian design, and we had a composite primary outcome of aspiration pneumonia, hypotension, and glycemic outcomes, hyper and hypoglycemia.
Brilliant.
And so in terms of the sample size calculation, we used the data from Chow Now, the best data that we had, and accepting a non-inferiority margin of an absolute difference of 3%, we estimated that a power of 600 patients would be required for a power of 80%.
And you also powered for superiority.
We did not set up to power for superiority.
Okay.
We powered for non-inferiority based on Chow Now,
Right.
and the results were interesting. We also, as mentioned in the presentation, we also looked at patient satisfaction score prior to the procedure.
Tell us about the patient population. Which patients did you, particularly relevant, I suppose, in terms of applicability, which sort of patients did you exclude from randomization?
They're very pertinent points. So we excluded all those who required an emergent procedure for obvious reasons. We excluded all those who required a general anesthetic, or all those who had structural cardiac intervention, such as transcatheteric valve implantation. Importantly, also at the time, due to the limited data that we had, we erred on the side of caution and did exclude patients who had an indication for planned calcium modification, and also patients who required cardiac resynchronization therapy, a potentially longer and more complex procedure.
Not unreasonable. Tell us about the results of the trial.
Yeah, so surprising results. So we confirmed both non-inferiority and superiority. And so the primary outcome event occurred in 19.1% of the fasting arm and 12.0% of the no fasting arm. And that 7.1% absolute risk difference correlates to a number needed to treat of around about 14. And so there were no episodes of aspiration event throughout the trial. So there were numerically higher rates of all the other outcomes within the fasting arm. When we looked at patient satisfaction, there was also a significant improvement in patient satisfaction based on a validated fasting patient satisfaction questionnaire with a Bayes factor of greater than 100, which means evidence of it as a decisive difference between groups.
That's very relevant and also very pertinent because we do a lot of procedures, but eventually patient satisfaction is something that's important. And that brings me to the question of the demographic characteristics of your cohort. I noted about 27% were type 2 diabetic, and this is a particularly problematic population when you think of fasting versus non-fasting. How or what did you mandate in terms of their insulin, and when did you look at blood sugar levels for the trial?
So in terms of blood sugar level monitoring, we mandated that a blood sugar level had to be performed within 2 hours of the planned procedure start time. And in addition, further blood sugar levels would be performed as a routine after if they were diabetic, if they had any clinical symptoms or there were clinical concerns, or if the initial blood sugar was abnormal. And of course, if the initial blood sugar was very abnormal, then we would obviously follow blood sugar results. In terms of the diabetic patients and how they were managed, we really did follow national diabetic guidelines. And so, for example, if someone was on a long-acting and short-acting and basal bolus dosing with morning doses, 100% of their basal morning long-acting dose would have been given in the fasting arm, but their short-acting would be withheld. And so that's consistent actually with national guidelines. Of course, if you are not fasting, insulin would continue as normal.
Brilliant. Another thing in terms of applicability of this trial in daily practice. So 70% of the patients were those that underwent diagnostic coronary angiography, 30% were PCI, and I think you noted that 30% were also stable inpatient ACS.
Correct.
So who might we think this trial will not apply to, and what do you think we need to do another trial for more complex patients?
Yeah, it is a very good point. And so we obviously, around about a third of patients receive coronary intervention, actually 36% in the no fasting arm and 30% in the fasting arm. And certainly these were stable patients. And so stable inpatient procedures were around 30% of the cohort, with outpatient procedures, elective procedures as 70%. You know, it's a very relevant and pertinent point that perhaps we were looking at a more stable population. And so there may be a role for another trial specifically looking at higher risk or more complex procedures, for example, chronic total occlusion procedures and those sorts of things. But I will mention that the TONIC trial, recently published, that included CTO, chronic total occlusion patients in their cohort. In fact, 10% of all PCIs were done on CTO patients in the TONIC trial.
That's interesting. And I also understand you're trying to do an IPD meta-analysis, pooling all of this data, which might be useful.
Yeah, it's exciting. We've reached out to a few of the other investigators of the other major trials, and we really appreciate their collaboration to try to get, I guess, a little bit more evidence to tease out more precise results overall for the cohort.
Okay, thank you very much. Really nice data, very helpful data for the practicing clinician, interventionist, and the patient. And congratulations.
Thank you very much.
Thank you.